Hi, welcome everybody. I am the executive director. I'm Jennifer Myers, the executive director of the Jennifer Bush-Lawson Foundation, and I am pleased to have you here for our conversation on race, bias, and equity in prenatal care. This is part of a new event series that we have been holding this year to talk about issues around maternal and infant care for vulnerable populations. I'm really happy to have our panelists here, our diverse group of panelists. Two of our panelists, Dr. Saran Wheeler from Duke Medical Center in Durham and Dr. Terry Wright from the Meyer Foundation, have also been working with our foundation on an award we're giving for innovative projects in prenatal care for vulnerable populations. So I'm glad to have them sharing their expertise. We also have Faith Ramirez, a nurse doula, joining us, and then Kayla Randall from Washington City Paper, and I think many of you have probably followed her series on maternal health in the district. I am also really pleased to have our event sponsored by the American Medical Association. And with us today is Dr. Aletha Maybank, the Chief Health Equity Officer for the AMA. And I'd like to have her come up and make a few opening remarks for us.
Good morning, everyone. A little more energy. Good morning. I know it's early. But I'm so happy to be here this morning with you all and happy to meet the panelists. We had a great conversation already back there, so this is going to be very good. But on behalf of the American Medical Association, we welcome everyone. And we thank you for your presence today. We thank the Jennifer Bush-Lawson Foundation and Jennifer Myers for hosting this critical event and bringing voices and minds and hearts together to talk about this public health issue that has really risen to tremendous light and priority in our country and now really among our public health and healthcare institutions. And again, I want to thank the panelists for lending their time and expertise with us over the next couple of hours. Many in the room may know the stats. Some of you may not know the statistics around it, but according to the CDC, the United States is one of 3 countries in which our maternal deaths are rising. And we have 700 maternal deaths per year, and an additional 50,000 women actually also suffer from serious life-threatening complications during or around childbirth. Black women are 3 times more likely to die from pregnancy-related causes, as well as Native American women, who are 2.5 times more likely to die than white women. And we know that 60% of these deaths are actually preventable. They are preventable. And we also know that our babies are also 2 to 3 times more likely to die within their first year of life than white babies. And so the AMA defines health equity as optimal health for all, and recognizes the importance and urgency of advancing health equity and addressing structural and social determinants of health, which you'll hear more about on the panel because I know the panel is well prepped and very knowledgeable about talking about structural issues. The term birth equity was coined by Dr. Joya Carrere-Perry, who's a friend of mine actually and founder of the National Collaborative for Birth Equity, is the assurance of conditions for optimal births for all people with a willingness to address racial and social inequities in a sustained effort. We know birth inequities arise really at the intersection of oppression and discrimination by race and gender for both Black and Native American women. What's really important for folks to understand is that these inequities don't just happen, really. They are produced. And the people who are negatively impacted by experiencing injustice are not the ones to blame. And it is clear that racism, discrimination, and bias at the provider, institutional, and societal level conspire and lead to inequitable access and quality of care, mistrust for healthcare, the institutions, response and delayed response for medical emergencies, along with a culture of disrespect and at times not valuing or listening to Black women. The American Medical Association supported legislation enacted last year preventing maternal deaths that supports state and maternal mortality review committees, also known as MMRCs. And just earlier this week, we had our annual House of Delegates meeting, and the AMA adopted policy to support legislation to extend pregnancy Medicaid to 1 year postpartum, understanding that there are absolute gaps in coverage. The AMA maintains a position of zero tolerance towards racially and culturally biased disparities in care, and there's evidence in both science and lived experience that tells us that implicit and explicit bias, I'm very particular about that. We can't just focus on implicit bias. I think sometimes that lets people off the hook. But both negatively impact the quality of care and patient safety. We at the AMA encourage physicians and healthcare professionals to examine their own practices to ensure that inappropriate considerations do not affect their clinical judgment. And we encourage more dialogue and, more importantly, more action to elevate the impact of bias as well as the action to quell it. To this end, we support the development and implementation of training programs regarding bias, diversity, and inclusion in all medical schools and residency programs. And actually, over the past 6 years, we've been working with 37 medical schools, a consortium, which is about a fifth of the medical schools within the country, to think about a new pillar, and they came up collectively with a new pillar of science. So not just basic and clinical science that they're typically taught on, but also adding a health system science. So they understand better the delivery of care and the systems that are set up to deliver care. And within the context of that, we created a text, and within the text, there is a chapter on social determinants of health and understanding bias, and it's going to be actually revised to include the structural determinants of health in its next version. We are very encouraged actually to see more hospital systems and medical schools taking on educating their students and physicians on bias and health equity more broadly. And we are also encouraged by the unique collaborations that are forming. However, we all know that there's way more work to be done. And lastly, I think it's absolutely critical to recognize and be thankful to all the advocates, the doulas, the midwives, patients who have really paved the way to elevate this crisis and urgent need for the country, for public health and the healthcare communities to pay attention and act. I feel, we are in the health community. We definitely knew the stats, we knew the data for a little bit of time. But in terms of this whole collective action and the urgency of it, it really came from the activists and the advocates who have been talking about this for years. And they remind us that equity is about valuing a woman and her family's experience as well as her rights. So as we move forward into the panel discussion, I just leave you with my sense of urgency, which is, I would assume maybe many women, as I look out in the room, sense of urgency is that I'm a Black woman who is well educated, of reproductive age, 2 graduate degrees, completed 2 medical residencies, and what I am and others that I know are keenly aware of is that these conversations are about me and about many of my friends. I am 3 times more likely to die of childbirth than a white woman who didn't graduate from high school, and 8 times more likely in my home city of New York City, actually. My child will be 2 times more likely to die before the first year of life. And that's stressful. And we're going to talk about what stress does as it relates to racism. And it's also scary to know that this is potentially what I have to, and many of my friends have to kind of look forward to. So, as with all inequities and the people bearing the burden of them, these are real folks and actual people's lives fighting not only to survive, but to thrive. We as organizations, healthcare providers, governments, philanthropists, media, have a responsibility and an opportunity to ensure that this happens. This protection of helping us thrive beyond survival happens. I want to say also, and this came as we were sitting in the room, and I mentioned it at the sitting room, is to really thank Jennifer for the panel today. Something that we talk about as women of color, and Black women specifically, is that oftentimes we're not listened to, and also we end up being on panels with a variety of people, but to have a panel that's of all Black women to speak voice and truth to power to the issue from different perspectives is a very leading thing to do. We just saw this week the NIH, if anybody paid attention to the NIH director, Francis Collins, said he no longer is going to participate on panels and really hold accountability to, yes, I think it deserves, absolutely, and hold accountability to ensure that we have diversity of people who are talking about the issues and who are also not only doing it in their professional perspective, but it's a personal perspective as well. So thank you all for being here today again, and it's off to you. So thank you.
Can you hear me? Okay. Thank you guys so much for coming. This is a super important panel and a really important topic area. And so I kind of want to start off with having our lovely panelists kind of introduce themselves, and so you can familiarize yourselves with them.
So I'm being looked at, so I suppose I'll start. It's wonderful to be here. Thank you so much for having me. My name is Saran Wheeler. I am a practicing maternal fetal medicine subspecialist. So that means I've been in school for longer than I care to recall. Did 4 years of medical school, 4 years of an OBGYN residency, and then 3 years of maternal fetal medicine subspecialty training. And now my primary focus from a clinical standpoint, I'm still very much an active clinician, was literally running to the airport from clinic yesterday. Most of what I do is I take care of women who have a history of a prior preterm birth. And I direct our prematurity prevention program, so surrounding those women with a variety of preventative services to try and prevent another preterm birth from happening. From a research standpoint, in addition to my clinical role, a significant the portion of my time is also research as well. And my research interest is in racial and ethnic disparities in preterm birth, and specifically developing interventions such that we can deliver preventative therapies in the most efficacious way to the women who most need it, which in my case often is non-Hispanic Black women in our community. And then the third hat that I wear is an administrative hat, in that I serve as the Director of Diversity and Inclusion for the entire Department of OBGYN. So many of the comments very much resonate with me, that I feel like in that role it really dovetails with what I do clinically and from a research standpoint in targeting programs that really target physicians, many of whom come in with very pure intentions, but throughout the course of training and life end up perhaps not providing the care that they initially set out to do so. So I look forward to talking to all of you and happy to answer questions about those experiences or other things.
Good morning. My name is Faith Ramirez. I am a registered nurse, and I've been a nurse for roughly 15 years, and primarily only in perinatal services. I started out as a NICU nurse and actually have a background in strategic planning and business management. My story starts at the crux of being a 21-year-old unwed mother and having to make the decision with a very lucrative job to decide to either maintain that pregnancy or to move forward and have an abortion. And I decided to continue with that pregnancy, and my first day of being a mother was faced with my child being transferred emergently to Children's National Medical Center, and basically being told 4 days later that she had a neurological condition that was not compatible with life, and that I needed to feel very comfortable taking her home and helping her to be comfortable that she wouldn't probably live to be past 6 weeks of age. So I'm happy to say that she lived to be 3 years and 3 months, and I pushed through with a child with a trach and a lot of drama and stress to get through nursing school. And I think I just told a room of people the other day that I actually celebrate the fact that Medicaid was very instrumental in helping me take care of that child, and that Affordable Care Act wasn't introduced at that point, but it definitely helped me to be able to take care of her with continuous medical support and then graduate from nursing school. So unfortunately, she died prior to getting that notification in the mail that I passed boards, but it was definitely the impetus to drive me to be a change maker in healthcare. So now I wear several hats as well. I've had 6 more humans since that point. So 17 years later, I have to say my story resonates with hope and faith and resiliency. And so with that, now I've actually left clinical care, and my story is just that I realized that my value system was differentiated from that of my peers. on the unit and the care that was being provided. So I felt as if I could do more change making outside of the system to try to provide support for people that actually did really want it to be better, but didn't have the resources to be able to do that on the level that they were at. And so now I've piloted Nova Birth Partners, which honestly has been amazing. We have roughly 50 support people on our team, anywhere from birth doulas, postpartum doulas. We have a licensed clinical social worker that provides perinatal services. We have lactation consultants, whether you're a nurse or not. We think all lactation consultants are awesome in our organization. And in addition to that, we've used that program to successfully encourage several local hospitals to partner with us to roll out on-call doula support programs that will be voluntary for new doulas that are seeking that collaboration on the physician level, but also a little bit more help. What does birth look like? How can I actually be conducive to helping, make change in the system? And so on top of that, my primary role is to work as a consultant with not only just obstetrics providers, so midwives and doctors, but also on the hospital level, helping to implement classes and programs. I tell people lovingly, I try to help hospitals learn how to be nicer to their patients. And then in addition, I've been very lucky to write some maternal advocacy bills along with some of the more progressive legislators in our local, state, and national level. And then in addition to that, work alongside insurance companies to try to figure out how to monetize services and then reimburse appropriately. Thank you.
So I do not wear 5 hats, or 3 hats, or 4 hats. Good morning. I'm Terry Wright, and I'm the Vice President for Program and Community at the Eugene and Agnes Meyer Foundation. I've been there for 16 months, and prior to that, all of my work has been in public health, either at the state level or in local communities in 4 different states, in the areas of state policy, as well as improving access to care for not only the maternal and child health population, but also children with special health care needs, WIC, and adolescents as well. So I've run the gamut in terms of that age group of reproductive health, or reproductive aged women and girls. And also have done quite a bit of work. My research actually was in the adolescent brain development and how they respond to risk, particularly sexual risk behaviors. So that's it.
Okay. So we're here to have a conversation, talk about how we got here, what changes need to be made, and what part we can all play in this issue. And so Terry, you brought a lovely handout, and I was hoping you could kind of lay the groundwork for how structural racism and implicit and explicit bias play a role specifically for women of color and Black women.
Mm-hmm. So I'd be happy to start, and some of you might have heard this if you were at the February similar gathering that was held here. I think it was actually Valentine's Day or the day before, something like that. So you might have heard some of this before. So my background has really focused very heavily in prevention and understanding by unpacking a number of the determinants that contribute to poor pregnancy outcomes, and or including infant or maternal poor pregnancy outcomes, and then thinking through what are the preventive aspects of that? How can we prevent it once we understand what the contributors are? Why does this how is it manifesting? What are the contributors, and how can we disrupt some of those contributors so that women of color can have healthier pregnancy outcomes, more of them? I too, as Aletha talked about, have been very disturbed, because this isn't even my current work. My current work is really around some of the, well, it's related, but it's not directly. It's racial inequity. The Meyer Foundation is focused on advancing racial equity through disrupting the systems and structures that perpetuate inequities and disparities. So it's related. It's just not in the health area. It's in the social aspect of it: housing, employment, education, and asset building, which are the social pillars, right, of well-being later on. And those, when there are inequities in those social pillars, you end up seeing the manifestation in one area, and that area is health. And that's what we're seeing in some of this data. When I was the maternal and child health director for 6 years for the state of Michigan back in the late 90s, maternal health was improving in this country for all women. The data where it wasn't was outside of outside of the U.S. In other countries, we still had major concerns around the women having healthy outcomes. But in the U.S., it was improving. And so it's disturbing to see the data going in the wrong direction. And it means we have to go beyond what we've been doing. We can't do the same things the same way and expect a different outcome, right? We've got to do something different. And to understand that, it requires that we unpack it. And that's what this diagram that I talked about many of these concepts, but I felt like I needed something else to capture it because it's multifaceted. There's no one aspect that contributes to this. So if you allow me for a minute to set the stage around what it means to connect the dots and unpacking, determining, and responding to the lived experience of Black and brown women in America. And I say America because it's very different, and we've even seen that where the children of foreign-born parents have different, what happens with the second generation, right? We have that literature to inform us that we're talking about America, all right, and what happens here in this country. So the first thing, some of you may remember that I spoke about the concept of weathering, that Arlene Geronimus has codified, if you will, has done a ton of research around and repeatedly discovered that being Black in this country is detrimental to our health, regardless of your age. That there are policies and practices that have for over 400 years and continue today, even though we like to think we're in an anti-racist environment, we are not. And especially in the current leadership or lack of leadership that we have at the White House, we have seen an even uptake of overt racism. And what the weathering concept is trying to capture is that we internalize that. It doesn't go away. Repeated assaults, we internalize that. And most importantly, it ages Black women physiologically. It ages us. And that's where Arlene found when teenage girls were having better outcomes than older women. And when she dug deeper, she was able to uncover that and label it weathering, that actually their bodies were older than the age, even though, we may look beautiful at older ages, because I'm probably one of the oldest women in this room. So we may look great at older ages. In terms of our bodies, tell us something different. And that needs to be accounted for because it means we start at a different place, right? Even though we're 21 on paper, or 23 on paper, or 30 on paper, we are older. And she has also reinforced that by saying that, by an additional piece of more recent research that uncovered that even when she looked at our DNA, our telomeres were compromised, which also contributes to our physiological well-being. That's even more recent research. It started in the mid-90s, 94 was her first body of work, and it has continued today, and she's been able to reinforce it through different research projects. So it's real, and we need to incorporate it in our understanding of the lived experience of women of color. Secondly, is that, and this has already been mentioned, but I'll say it again, it bears repeating because there's a distinction I want to make that I don't think was made in the New York Times article, and it was a missed opportunity, in my opinion. And is racism and implicit and explicit bias are alive and well. And that is regardless of socioeconomic status. All right, the article, the beautiful New York Times spread, started the conversation about poverty and how it impacts, and then ended with the fact that that the issue of maternal health or maternal deaths transcends poverty. I wish she had started with at the beginning of the article, that it's regardless of SES, of how many degrees, how much education, how much money, whether or not you're insured or not, whether it was a planned pregnancy or not, that this still prevails. Racism and biases are very present, and they're in many ways unconscious. So until we make them conscious, lift them up and make them conscious, no shame, no blame, but recognizing that we are creatures of how we were raised, and we are creatures of the environments that we were raised in and educated in. And so so it's not blaming anyone, it's recognizing that those biases exist. And so when you recognize it, you can do something about mitigating them and how it plays out in practice. The third fact I'd like to illustrate is that as a result, and they're all related, so this is not disparate that some women will have it and some won't, all right? This is all interrelated. That with these experiences on a day-to-day, the microaggressions that we experience, it produces a toxic stress environment for us. That if you look across the data, whether it's women or men, when you look at our life expectancy, we die earlier. And there's a reason for that, okay? Yes, we can go to the chronic diseases. You know, we have more diabetes, more hypertension, absolutely. The question is why? And it's not just about diet and exercise or having access to a grocery store with fresh fruits and vegetables. Those are all important, but you can do that and you'll still have some of those challenges. And so recognizing that chronic stress, which causes, if you have had an opportunity to see Unnatural Causes, it really demonstrated it very clearly, that 6-part series. If you haven't seen it, it's still available. Watch it. It shows the effect of chronic stress on elevated hormones in our body and the potential impact of that normal cycles. The stress hormones go up when needed, and then they retreat to a normal level. With chronic stress, they don't get to retreat. And I'm oversimplifying this, forgive me, the clinicians in the room. I realize I'm oversimplifying it, but for the interest of what I'm illustration of this in this conversation, it's present and we internalize it, and it maintains increased or higher stress hormone level that has been found to be toxic and problematic to us physiologically. So you couple that with the microaggressions and racism we experience every day and how that relates, and the fact that we already started out behind the 8 ball with weathering, and then you have a pregnancy, okay? So you already have, and I'm not trying to, please do not interpret this as women of color are compromised. I'm saying this is the lived experience of women of color, and it does not go away when she's pregnant. Okay, and it's not related to, it's not determined by poverty. Poverty exacerbates the situation, but if she was wealthy, these dynamics would still exist, and that's what Unnatural Causes uncovers for us, and it shows you the impact physiologically on that person's body, male or female. So with that, we have this increase now of poor pregnancy outcomes in the form of maternal mortality and morbidity, all right, and that our Aletha was able to introduce us to, that yes, we have the maternal deaths, we also have morbidity as well, which is, you know, you're focused on the maternal fetal aspects of that and the high risk nature of it. And we have to be able to recognize it. Finally, and then I'll shut up, what are the implications? I don't know if you want to get to the implications later, if you would like to hear first, and then, because I see I'm watching the time, and I want to be mindful of that. So I can get to it later.
Do you want us to come back around to that?
If you would like to.
Okay.
I'm not sure how you're going to,
Okay.
All right.
Well, one of the things that you touched on was that some of the issues we face are kind of uniquely American. And so I would love for you guys to chime in on what your thoughts are on birthing culture, specifically in the United States.
Okay, everybody's looking at me again. So the birthing culture in the United States. I think that there is a very unique tension in the setting of birthing. And I talk about this all the time, specifically as being a physician. I have this tension of, on the one hand, I'm the one physician who on a routine basis gets to see women in the happiest moment of their lives. I'm the only doctor who gets that on a routine basis. On the other hand, because I'm in this space where a lot of people go into the birthing experience almost like it's a wedding or the baby story, and there's this overly idealized view of what it's going to be like, and often an overly rigid idea of what it should look like, that it can be very challenging for particularly physicians in my space who are dealing with exceedingly high-risk pregnancies, where the stakes are incredibly high for that baby and for that mom, and it can be challenging because the recognition of how high the stakes are oftentimes can be difficult for patients to appreciate. I say all the time, when I do a really, really good job and the woman walks out of that hospital skipping and dancing with her beautiful baby, she has absolutely no idea what might have happened in that operating room. I remember distinctly being a resident. We had this woman who was delivering. She had a cord prolapse. That's an obstetrical emergency. Also, this woman had a history of multiple abdominal surgeries. So I was expecting that she would have an abdomen of cement. And she needed a stat C-section. And thank God when we got in there, we made one incision, got right in, got her baby out like that. She had a beautiful kiddo. And so she walked out of that hospital having absolutely no idea how close she came. And so I struggle in this tension of wanting it to be that beautiful experience for women that I know you have so much expertise in, and reveling in the beauty of the fact that I get to experience women in this happiest moment of their lives, with the tension of knowing how high the stakes are. And how do we marry those tensions? And I think that's where a lot of physicians who are incredibly well-meaning tend to find themselves. Particularly in the United States, going back to your specific question, I will be honest with you, in the litigious nature in which we practice as well, there are so many external pressures on physicians, not to let us off the hook in terms of this is the job that we chose to do, but there are so many external pressures that living in that area of tension becomes very, very challenging. And having those conversations and honoring what is supposed to be and should be a beautiful experience with that woman, with the tension of the very real medical consequences that are at play in that moment, in the greater context of the litigious nature of being in the United States, and quite frankly, all of the monitoring and all this stuff, sometimes extra information just creates a nightmare. It becomes a very, very challenging space to be in.
Yeah. Did you have thoughts on birthing culture in the U.S., Faith?
So,
A whole lot of them.
I'm sure she does.
I know you do.
The wealth of what you said, I want to preface with the reality that I spent almost a year working as a legal nurse consultant. And I actually worked with a very reputable firm that was really good at taking OB's money. And, it presented that dichotomy of being a nurse in the system, but then also working alongside a very prominent lawyer who, went above and beyond to remove himself from the empathy of the system. Yeah. And so that really is the beauty of where I'm coming from. Yeah. Because when we create this support platform that ultimately we want to undergird all that you're doing, the dynamic of the support providers that I tirelessly work to provide work-life balance, fair compensation, and just an appropriation of respect. It's hard because in a lot of ways they think that we're championing the miracle birth minus all of the complication.
Yeah.
When you have a nurse on the team that gets both sides, we're actually right behind you, but at the same time we're right next to you too, because we want you to have an even better relationship with ultimately the reason why we're here. And that's what I think sometimes is what's really on the table, is that the more collaboration and the more respect in the birthing situation, then we can actually look at birth as a physiologic process, but that family can also understand that with physiological processes, it doesn't mean it's gonna be perfect. And it definitely means it's unpredictable. So by providing, honestly, that ingrained support system, as soon as she realizes she's pregnant, when she calls the doctor and says, "Hi, I'm pregnant," I know because now, I can find out before my missed period. The doctors, they're well-meaning and doing all that they can do, but their staff represents them at that point. So from that very initial interaction, we're telling you, you're important, but you're not important enough until you're closer to 8 to 10 weeks of pregnancy. So at that point, we're already starting behind.
Saran, I'm really interested in your work, particularly with the diversity and inclusion, because I think, a lot of times we champion diversity in all things, and making things more diverse can only help. So I'm curious how you go about accomplishing, or what your goals are.
Sure.
And how you go about accomplishing making your environment more diverse.
Sure. And so I spend a lot of time actually separating out the two concepts of diversity versus inclusion. And if I had to pick which one I actually probably focus the most on, it's actually inclusion. It's actually creating an environment where everyone can bring the full armamentarium of their skills and their talent to the table.
I'm working with you.
I say all the problems are just too big. I don't care what you look like. I don't care what your background is. If you have any shred of intelligence and you have any shred of ability, I want you at the table, and I want you to use every single bit of it to take care of these women and provide them the best outcome that we can. And so therefore, the environment and the soil that we have is just so important to me. With that, if we do that, the diversity will come. And the diversity that's there will be so much richer and so much brighter. And so I'm the first person actually in our department to hold this role. It was a new role when I started it on, and I spent a lot of time working with my chair about telling him what I was going to do and what I was absolutely not going to do. And what I was not going to do was to create any type of spreadsheet where we were going to have this many black people and this many of this color and this many of that. No. I wasn't going to do any of that. What I also was not going to do is sit in a room with like-minded people and wax and wane poetically about diversity and inclusion. I don't have enough time. I'm sorry. That's time I could be sleeping. I'm not going to do it. And so we were very, very intentional about really creating these programs that we have that really do focus on that inclusion environment. I think there's a big intersection between what we do and just wellness. We know that these biases tend to rear their ugly heads when people are sleep deprived, when they're feeling pressures at all sides. So you take a poor obstetrician like me and you put her up until 3 a.m. and suddenly there's a stat C-section and this is happening and somebody's bleeding out in another room. That is a very fertile ground for biases to come out. So trying to understand the full bevy of pressures that really are surrounding providers, and not just physicians, our staff, our trainees, everybody in our department, everybody who is truly a care provider, because it is a care team, that has really been our focus.
And so, just sticking in the kind of medical world, at the February panel, there was a really great audience question that was posed. It was, what are medical schools doing to train doctors about implicit and explicit bias? Mm-hmm. And I was wondering if you could speak to that.
Yeah, I can talk a little bit about that. So we heard some of that in the opening comments. One of the things, and there's still a lot of work to be done, but I think progress is being made. I will say that. Duke now, and I can speak most to the Duke Medical School now, has a social determinants of health course. And one one of the things that was very, very important to me as director of diversity and inclusion was making sure that OBGYN and women's health was at that table. And so I charged one of the members of our committee to ensure that she's actually a teacher in that course. She's supervising what is the material that's being taught in that course from the women's health lens and from that perspective. So is there work to be done? Absolutely. And in fact, there's been some challenges even with that course. It has been challenging, I think, for some of the students to hear about concepts like privilege, about structural racism, about bias. It's been difficult, I think, for a lot of them to really, truly look in the mirror and honestly with themselves, and it creates some uncomfortable tensions. But strides are being made, and I'm very proud to say that our department is absolutely at the table at Duke as these conversations are happening.
Terry, did you want to?
I just wanted to add that and actually I think Aletha was going to say something about what's happening in medical schools too, weren't you? Elaborate? Oh, okay. All right. So I wanted to point out that I just wanted to reinforce how difficult it is to have those conversations and recognizing it and also and how critically important they are, because what we don't want is for our providers to believe that because you're Black, you're at risk, as opposed to it's not, in other words, it's not race, it's racism is the enemy here. Not because of the color of our skin, it's racism, how we are treated because of the color of our skin. And that's very different and very important for clinicians, any provider, doesn't matter, any provider, to recognize the biases associated with that and not get hooked into the short version, or which is inaccurate, that, okay, it's all Black women, it's all brown women. That's not what we're saying, right? We're saying how important the lived experiences is, and that those lived experiences are alive and well in our mental and physiological well-being or illness, and they have to be surfaced and accounted for, and how we're treated both interpersonally and clinically. And so I'm happy to hear that at Duke, one of the leading institutions in the country has taken that on and recognizing the challenges and hopefully providing the support for, developing clinicians to be able to be comfortable in raising those difficult issues, because they are painful and difficult.
I love what you said about it being racism
Yeah.
and not race. And I think we need to shift even, because when I went to medical school, one of the first things you get taught are, these are the risk factors for this condition.
That's right.
These are the risk factors for, and
Yes.
African American is always, I mean, it got
Always
just
a risk
depressing
factor.
to go to lecture. It was like, good Lord, what disease am I going to get next? But
Right.
you're right. It really shouldn't be African American. It should be, has experienced racism chronically.
Yes.
That's really
That's what we're
that's what the
talking
risk
about.
factor
Yeah,
is.
it's not
Yeah.
race.
Yeah. Yeah.
So, and it's over time.
Yes.
It's not just while you're pregnant. It's over time, right?
Yeah, and there's a lot of literature to support that.
Yes,
It's really
absolutely.
chronic stress that
Yes.
really is probably one of the bigger problems in terms of pregnancy outcome as opposed to acute stress. Both are important,
Yes.
but it's the chronic stress that
Right.
really.
So Faith, hi. You're local, which is wonderful, and Virginia's governor recently announced a plan to eliminate racial disparities in maternal mortality by 2025. So that's just 6 years from now. So I'm curious, in your opinion, since you are local and you can speak to that, how can we get there? Is that feasible, and what systems need to change to make that goal?
That's
That's a great question.
I'm sorry.
That's a great question. Especially in Virginia right now.
So with all due respect, one of my greatest challenges being local to Maryland, DC, and Virginia is that in the explosion that occurred within our practice, I was minding my own business in Virginia. We created 4 locations in a very short period of time where clients could come in and receive services from a wealth of clinicians from various demographics, and I was starting to actually get more interest from residents of DC and questions about whether or not we would be willing to service them in the district. And with that came additional requests for services from families that could not initially afford our services. So very quickly, we created a self-funded program where at least 20% of our services are gifted to families in need. And really, to qualify, either you're a Medicaid recipient or you have a history of birth trauma in some regard, and financially you really need the service but can't, capitulate the ability to do so. So something I'm known for is being very candid, and I vacillate in that area painfully so, because the reason why I am an advocate is because of lived experience. The reason why I'm here is because we have decades of data of families that have children that have never met their mothers. And I don't just mean children that have mothers that have died. I mean children that have mothers that have never been able to grapple with a very traumatic birth experience that didn't necessarily just relate to that birth. It could have been the postpartum period. Having mothers come to me saying, I didn't realize I had postpartum depression until my third child. Okay, well now we're talking about intraconception health that's been compromised from your first birth. And so to hear the governor say that, thank you for saying that. Where I'm at is, I actually contacted the governor's office 5 days before I even knew of the press release, where there was a requirement for postpartum information to be provided on the clinical level. I will say that's wonderful. However, once that information is provided, what are we doing with it? If we're going to screen, are we going to then incorporate screening? Once we screen, are we going to actually help these families get connected to not just some sort of psychiatric or psychological support, but perinatal specialty support, right? So it's so much more than just the mortality. And the fact that we referenced just that piece means we're missing the boat. What about the 50 to 60,000 families that are documented that have exhibited morbidity as a result of their pregnancies or birth or postpartum? There's so much more to do that if we don't go to the beginning prior to the birth even happening, then it's not of importance to just focus on the death. There's so much preventative opportunity that I invite the governor and the governor's office in Virginia to answer my emails that I've sent over the last several weeks so that we can have a conversation. The money's on the table. I will say I believe that the legislative bodies, the federal establishment is definitely doing their piece. I think AMA and ACOG, they're doing their piece. I would love to see the hospital associations step up to the plate and make it a priority. Yes. I would love to see more of, the players at the table invite more diversity in conversation and also in position. Those are the things that have to happen. And if the governor wants it to happen in 6 years, we actually have funding that will enable that to occur if we can actually all sit at the table and decide where that funding goes.
Right. And so that's a good segue into, I kind of want from each of you, from each of your different perspectives and how you relate to this issue, what you want to see, what changes need to be made, and not like, I know people like to say kind of like a little in the future it'll get better, but what do we right now? What do we need right now?
So you want me to?
Sure, yeah.
So then she's looking at me.
Finally.
So some have already been mentioned, but it's captured here as well. The first and foremost is, I think, so I framed it as the implications for prenatal and postpartum care and the systemic, because again, this is not about the individual. This is looking at the systems and structures that focus on that individual, right? And so honoring the lived experiences and understanding the complexity of that, and that it did not go away but has been internalized and continues every single day in one shape, form, or another, whether explicitly or through microaggressions. It's alive and well, either for you, your family, your children, your parents. I mean, it's just omnipresent, and recognize it because it has an impact on our well-being. Clinicians must acknowledge, understand, and reckon with implicit biases through education and training, right? So whether it's education, I see that at the med school and the residency level. Training, you know, you have to do continuing education credits in order to maintain your license. So doing programming through that mechanism so that we get the current doctors. Like, I fear, what are those doctors that were part of that yearbook at East Virginia Medical College? I fear, I hope I don't come across any of those doctors that were trained there at that time, right? Because that perspective where blackface is acceptable to put in a yearbook was prevalent. It wasn't just Northam, Governor Northam, it was others as well. So what are those clinicians doing today? Who are they caring for? And what are they thinking when they're caring for those clinicians? And that's where I got, and never hearing a message from the president of that college about what they're going to do differently, it incites fear in me. I don't want to come across any of them. And so that retraining as well as education in the process of becoming a physician or a specialist or a nurse practitioner or a psychiatrist, whatever the dimension is of being a provider, this must be understood. And then the third item is a different care regimen. When I was MCH director, it was at the time when the intervention for HIV proved to be successful in the clinical trial, perinatal HIV, and the clinical trials were broken. And I had to make a policy decision about how we were going to respond to that for the 30,000 births in the state of Michigan at the time, and whether we were going to require HIV or how we were going to handle it, because that was at the time when a positive test for HIV was almost certainly a death sentence. Okay, now it's a chronic illness. Thankfully, to science and research, we now have it's in the status of a chronic illness. At one time, it was pretty certain you were going to die, okay, if you had HIV. And so recognizing that we had to retrain all of those doctors, and we had to change clinic regimen, because we had a team with the hospital, so Michigan Hospital Association, et cetera, and we had to encourage and push for a change in protocol around how OB patients were managed within the new world that we were in at that time. And so I'm here to say that it may be more frequent visits during the prenatal period, definitely during the postpartum period. Waiting till 6 weeks for a woman of color is not necessarily the best thing to do, even though that's the standard that has been tested and proven over and over again. I think we have new information that pushes against those existing standards that requires that we reconsider how and when that care is delivered and what kinds of questions are answered. But that's also contingent on hospital protocol and payers, right? Because that's what we're going to hear. Well, we don't get paid for that. You know, I'm not paid. That's another system that must be informed and challenged to think about the care. That a cookie cutter model doesn't fit every woman. And I know physicians know this. I'm not suggesting that they don't at all. It needs to be embedded in policy and practice so that they are reimbursed. They may know that I'm going to need more than the 9 to 12 visits prenatally. They may know that and say, you know what, I really need to have X number of visits with this patient. I need to see her more frequently, even outside of what the current protocol stands. But then that physician gets pressure from the system about how is it going to be paid for, and getting approvals from payers to do what they know is right for the person. They get a lot of pushback, subtle and overt pushback, like how many patients you're going to see in an hour. You know, those kinds of expectations put pressure on the practice that may be inconsistent with pursuing a healthy outcome and responding to what's needed. So, and I know we always think that treating everybody the same is the way we should do it, right? I'm not prejudiced. I treat everybody the same. I'm not racist. I treat everybody the same. How often do you hear that?
Thank you.
Over and over again. And I'm saying that this may be a scenario where we don't treat everybody the same, that we recognize the lived experiences of women of color and how it manifests and can play out physiologically and mentally, and that we have to do something different because we're not all the same. Okay, I come to the table with Jamaican roots, raised a certain way, whereas someone comes to the table with Southern roots, raised a certain. We're not all the same, and we have to be able to adapt those protocols based on the lived experience of who I am, not necessarily who you are or you, but who I am. And that's where that personalized and tailored approach must be paid for by the payers in order to release that kind of opportunity for clinicians and the ancillary providers that support healthy outcomes.
That was great, thank you. So I'd love to open it up to questions and comments from the audience. I don't know if anyone, you have a question?
Hi, my name's Maya. Nice to meet you. I'm a rising senior at Duke, and I've been back and forth about pursuing medicine to begin with. I wonder if you guys could speak to the experience of becoming, I'm not sure how many of you are medical practitioners yourselves, but did you have to face any kind of obstacles related to your race or your background in the process of getting to where you are now?
Wow.
That's a great question.
Yeah.
Everybody's going, I knew y'all were going.
I'm not a clinician.
This was actually like appropriate. That's
right.
right. No, I'm happy
not a
to speak to
clinician.
that question. So just so everybody, make sure everybody heard, the question was, and it was a great question, as somebody who's training to become a practicing clinician, what, if any, and you tell me if I'm paraphrasing it wrong, what was your experience in terms of experiencing bias, and how did that play into the training environment? Does that pretty well encapsulate? So it's interesting. I experienced it, but it's sort of sad. I was almost so used to it that in a weird way it didn't bother me.
Nope.
So there were times when I would walk in the room with my white coat on, with a stethoscope around my neck, and the patient would look at me and say, "Oh, my breakfast tray's over there,"
Right.
assuming that I was the food service worker. And you know, it's funny because the first couple of times it happened, it actually didn't even bother me. And I was just like, oh, that's fine, you know, and I just sort of blew it off. But then you realize over time, I think it really speaks nicely to what you were talking about in terms of weathering, you sort of start internalizing these things over time. Yeah. And then once I started talking to my other counterparts who weren't of color and what their experiences were like with patients and realizing how different it was, that's when my eyes really started to be opened. When I would walk in a room with a white male counterpart and immediately they were treated with such deference and respect in a way that I wasn't getting at all. That was when my eyes really started to open up to it. I will say on the flip side, I would say, yes, those things happened. Did it impact me? Like I said, I think on a subconscious level, and I'm certain that it added to weathering. But I will say, I think, and maybe this is just me being slightly an optimist, I will say I think the positive experience was much more salient in my mind than those negative experiences. It was the time when I would walk through the hospital cafeteria with my white coat on and a little kid would come up up to me and say, "You're really a doctor?" Indeed I am. Indeed I am. You know, it was when I graduated from med school, I got a t-shirt that said, "Trust me, I'm a doctor." And I refused to wear it until I actually got my diploma. And then when I wore it, you know, people would come, "Is that really true?" Like, yes, I really am. Or walking into a patient room and the little kid says to me that they want to be a doctor too. And those opportunities to really connect with people who do look like me, who may not have seen a doctor who looks like them previously. I think that overshadows most of the experiences that I have had with discrimination and being treated differently, although they have happened. Yeah.
So I would agree with many of very similar experiences. And I think also the network of having other Black med students, especially, because there are organizations, the SNMA, the Student National Medical Organization, which, you know, and I will say as the American Medical Association, it is well known that we actually excluded Black physicians from 1847, from when we started to about the 1960s. And we issued an apology in 2008. But that has tremendous effect, and that's why the National Medical Association actually started, and Black physicians knew they needed to convene in order to advocate for their own rights. And so medical students very much was a strong part of who we were as a medical student, to kind of come together and to have that support. So I want to mention that. And then the other thing that actually recently happened again at this meeting that we had, our annual meeting for American Medical Association, our conversations, and I actually sat in with doctors, you know, and AMA is working on their diversity for sure. We're having more and more diversity over the years. But there are still rooms where there aren't many of us, you know, present. However, I was very inspired by a conversation. There were probably about 40 or 50 doctors that were part of the ethics committee, and starting to talk about discrimination against against physicians by patients. And what is it that we need to do in terms of policy and advocating to, one, acknowledge that this discrimination does happen, these experiences do happen, and what do systems need to do to respond to it as well as to prevent it. So we are starting to kind of see that tide shift a little bit, which is good.
Question.
Yeah. Oh, hi, my name is Brittany. I'm a second-year medical student. Do you want to grab that microphone? Yes, I will. I'll do that. Okay. Hi again. So I'm a second-year medical student. I'm a governor in Houston, and I'm also on SNMA. I'm on the e-board, and I'm really trying to. I work with our Office of Diversity and Inclusion, and one of the things every year, this past year, we're trying to get more of my classmates involved, because I think this is such an important conversation that we all need to have, and not everybody who looks like me needs to be at the table, because it's an everybody's issue. So I was wondering if you could give me any ideas that I could bring back to my school of trying to get more of my classmates involved in this type of conversations.
You're looking at me, so it's fine. No, and I absolutely echo what you've said and completely agree with you that this is an everybody issue. I tell people all the time, this is an all hands on deck thing. We need every single person at the table, because at the end of the day, it touches everybody's lives. The disparate, I mean, even if you let's just take out the moral argument. Let's just completely remove that. If you just think about the economic implications of health disparities, of lost potential, of people not being able to bring their full skills to the table, even if that, we all have skin in this game. There are some practical things that I do think help, and you know, I struggle with this tension of, do I make people feel more comfortable and use these other terms, and sometimes that helps to get other people to the table. But then once you get them to the table, you can start making them uncomfortable, and that's fine. But there are lots of times when I use, like I said, I use the lens of wellness. And I'll talk about that, about how this is an issue of wellness and things like that, how this is about physician burnout. And you can come at diversity and inclusion from these different angles, because I really do believe that these other constructs ultimately exacerbate a lot of the biases that are either below or, quite frankly, above the surface. And so I do sometimes couch conversations in those terms, and I do think that that will make other people who would be uncomfortable and feel like they are either unwelcome or don't belong at the table with these discussions much more likely to come to the table. And then once we've made people comfortable, then we make them uncomfortable. And we have that conversations, and not just for the sake of making people uncomfortable, but to have truly important conversations that we need to have.
Oh, sorry. Do you want to go to the? Thank you for going to the mic.
Hi, everyone. My name is Mary. I'm a social psychological doctorate student at GW. I also have a public health degree from Emory University. And I actually, thanks to Shannon and the team at Howard Medical School, I've actually had several opportunities to teach some Howard Medical students about social determinants of health, and most recently including the biases that I'm learning in my social psychological classes. And I just want to make a note that, like what you're saying, this is an everybody issue, an all hands on deck issue, because when I enter into those spaces of all Black medical students, it's really disheartening to know that even Black folks don't know what's going on to them, especially at that level. So I just want to make a note of that. And then also my advisor, Dr. Lisa Boleg, we're working on a maternal health checklist specifically to encounter some of the racial inequities that we're seeing specifically for prenatal and maternal health. So I just want to know, just largely and in general, you all mentioned some of the things that we should be looking for and accounting for. There's a lot of data that's been backed years and years of this issue, but like, what should we be accounting for now? What type of data should we be collecting and analyzing so that politicians, policymakers, physicians, everybody knows more about this issue?
I would say one thing I would add to that, if they have any history of birth. I know that as a clinician myself, when I'm doing the intake process at the hospital, when someone's actually physically in labor, we don't actually ask them, do you have a history of postpartum anxiety or depression? Do you have a history of perinatal, meaning prenatal or after? Mm-hmm. Have you had any mood disorders that have been documented or undocumented for this existing pregnancy? I think that another thing that I'm not seeing discussed is homelessness. That is something that is prevalent in DC. It is, probably more prevalent than several cities across the nation and states. And I just had a wonderful opportunity to talk with the Department of Health and Human Services in the district, and to say that in my pioneering of scavenging for statistics, there is no information that currently documents how many people in the district have either experienced homelessness, pregnant, or newly postpartum. So those are some of the things that I think we need to be discussing and we need to bring to the table, because if we're focusing on, are you taking prenatal vitamins? Does this mom even have somewhere to safely store them? Our conversations have to definitely undergird more of the social determinants of health, because I will say, as a nurse, I'm very disappointed that that's terminology that's not introduced in the health system as a nurse on the floor. Nonetheless, obviously, as a nurse, in school, community health is one class out of many. So we really need to start there. So reformatting the intake for the perinatal period entirely should focus more on the social determinants of health.
Ditto. Can I come? I'd like to also suggest, I would suggest to you, and you're a psych PhD student, I think I heard, right? Social psychology. I would encourage you to go back to Maslow's hierarchy, okay? Because it's real today. We know what's at the base of Maslow's hierarchy, and we know that how important it is to have those needs met before you can move to the next level for development, right? And that also shows us a potential frame for what questions need to be asked, like around, do you have safe, reliable shelter or home? Do you have access to quality food? Do you feel safe in your home? We call it domestic violence, And that's a loaded term, as opposed to, do you feel safe at home? Do you feel safe in your community?
Correct.
Because not only is that affecting you, it's affecting your other children, your whole family. If you're not feeling safe, and you have this, if you're hearing, whether it be bullets or airplanes or helicopters over, whatever it may be, are you feeling safe in that space that you and your children and your family are not in harm's way? So, and that's in the hierarchy, right? So I think if you start with the hierarchy and think about our experiences in those different elements, it will generate a tablet of what kind of data should be incorporated and questions asked, data collected in an intake, and what's more important is what happens to it afterwards. Because if you ask me, you better be able to do something about it or help me. And that's what I've heard in the past, that some clinicians or providers, I don't want to use, but are uncomfortable asking those questions because they don't know what they're going to do with the answer, right? Because I can't if you don't feel safe, I can't make you feel safe, right? And this is a one-on-one interaction. So if you're telling me, you're expecting something from me. And so having the resources available that the providers are intimately familiar with, that they can do a warm handoff so that, okay, it's important for you to get help. And here's a place that we know helps women in this circumstance or families in this circumstance. And they will understand because they know what that means during the pregnancy period as well, or perinatal period as well.
Correct.
So that's what I would encourage. If I had the magic wand, I'd start with Maslow's hierarchy.
Yeah, I would echo what you said, especially about being able to do something about it. I say all the time, we talk, there's an increasing conversation about physician wellness and things like that. And I say all the time, if I had to pick the number one thing that contributes to my overall wellness as a physician, that allows me to go home and put my head on the pillow and sleep at night, it is absolutely unequivocally our social workers in our clinic. It's our social workers and our pregnancy care managers. It's knowing when I ask that question and I go there with that woman that I have somebody, exactly. And that's why I think the work that you're doing is just so incredibly important in terms of these wraparound services. Even with all the years of schooling that I've done, I jokingly but truthfully say to patients all the time, I'm a one-trick pony. I know how to do one thing. I'm real good. If you need to get a baby out in like 5 minutes, I'm your girl. I know how to do that. But if you tell me, exactly. But if you tell me you have housing insecurity, all of these things that are so incredibly important to getting you to that ultimate goal of a baby, that's not me. And it's very important that I have these other colleagues where that is them.
Yeah.
I just want to add to that. What I love about what I do is if I get the opportunity to communicate our services or our impact statement, I have immediate buy-in from all of the colleagues that we intermingle with. When you walk into a room and you tell, a room of physicians that really time is of the essence in all that we do, that I'm actually here to support you and supporting what you do. I'm not here to argue with you. I'm not here to advocate on behalf of anyone. I'm here to help, really honestly provide that holistic care. Because if you're a physician, the reality is if you have a 15-minute appointment and she really needs a 45-minute appointment, you don't want to turn her away. But you also don't want to give everybody thereafter a 7-minute appointment because they may additionally need their full 15 minutes as well. So what do we do in the meantime? Could we have longer appointments? Sure. But where's the money coming from to support that structure? In the reality where we are at, we have to work together. I love to tell people, cancer's got it all figured out.
Yeah.
All figured out. They are eons ahead of us. I mean, it's even to the point now where the number one cause of death for a lot of populations isn't cancer anymore. What are they doing that's so different than what we're doing? It's something called interdisciplinary care. It's a standard of care. To look at obstetrics, why is that not a standard of care? Why would a physician with so much on their plate hold all of the liability?
Yeah.
when you really look at it, they hold the liability. It's not the hospital, it's the physician. And what happens is we're basically, trying to mitigate risk, but we're not fairly doing so because we're really not standing in support to provide systems to support them. So when you look at it, should the patient really have to pay for the holistic care when that's really the governance of what we're supposed to be providing, that experience? Well, that's where our system is. I would be remiss if I didn't bring up, our family leave policies, the fact that, 6 weeks, what if you have to go back to work in 2?
Yep.
I was one of those people. I had to go back to work. I had to go. I had to figure out how I could keep my body from deciding to drop my uterus on the floor, while as a nurse I was working 10 hours before I could go to the bathroom, and also figure out how to keep myself from, spewing milk like a cow when I was rearranging people's Toco belts. So with all of that being said, I was in a system promoting wellness for my patients while sacrificing my own wellness, and physicians are running in the same game. So yes, I believe that collaboration is a necessity, it's imperative, it's the only way.
Are there any more questions?
Hi, my name is Liana. I'm a master's student at Johns Hopkins, and I work up the street at the Center for Health and Gender Equity. My question is about implicit bias training. There's been some controversy around how successful those training programs actually are, and especially if they're being implemented as like a one class that you take out of however many years of training. I was wondering if you could speak to that and how medical schools are trying to address those issues.
So I can absolutely talk to that, and you're absolutely right. There is a lot of controversy, and I don't think we know yet. I don't think we know the answer. I think that number one, that leads to the fact that we need a lot more research. I will say that Duke was recently awarded a grant by the NIH. It was a U grant to create the Reach Equity Center. And one of their major projects is actually unpacking implicit bias training. And how do we deliver that training in a much more responsible way? Because you're absolutely right, a one-off is probably not doing anything, and in fact, there's some evidence to suggest it might be harmful. So I think that you're absolutely right. Where that starts is absolutely data. I struggle with this tension of, yes, we need data, yes, we need research in order to know exactly how to best deliver this education and this training, versus something needs to be done absolutely right now. And I'm not comfortable with the idea of, well, let's just wait 20 years until we have all the randomized controlled data to tell us exactly what to do, and in the meantime, we're just not gonna do anything. And so I do think that there's this idea of starting somewhere and then iteratively improving what we do as we get more and more data. And that's really been the approach that I would say I and our team and the folks I would say collectively at Duke, I think are taking at this point. I think at least starting with the language. And one of the ways that I couch it, and again, maybe this is me making people feel better a little bit, but these terms, implicit bias, equity, equality, all of these terms are common in the vernacular. And what I say, especially to my academic physician colleagues, is, you know what, when you go up for a promotion or for a job and you interview for a chair position at another institution, they're gonna wanna hear what you think about diversity and inclusion, because it's true. They're probably gonna get asked about it. So it is important that you at least have the language and have some ability to conceptualize these concepts and talk about them intelligently. So at the very least, I'm starting there and at least introducing the language and the vocabulary so people start understanding that these things are real and it's a thing that exists. And as we get more and more information, we iteratively get better and better.
Can I just add one little thing to it? That some of the indicators are that where there's a practice environment, right, where there's a safe space to practice, that you get a deeper learning that's internalized at the behavioral level, right? And that how critically important that the one-offs or the 3-hour class, you check the box and it's done. That's not it. That's not what we're talking about. In fact, it's insulting, quite frankly. And so it's really about being able to practice what the learning is in a safe place, because we're not trying to shame or blame anyone, right? We want to change behavior. So you have to go at it based on how do you change behavior, right? Just because they have multiple degrees doesn't mean that they don't need a behavior change, right? Or can't change. They can, but there has to be a process to achieve that and measure it as it's moving through.
And if we can change, just add on one more piece, and if we can change behavior, I think sometimes we have to go a step level. You know, I talk a lot that this work is also about changing not only minds but hearts.
Yes.
It's about shifting critical consciousness about how we understand our work, our world and our work works, and how we operate through it, and how other folks operate through it and make the decisions in the context of society. One of the other points, just in terms of not just training alone, I also just recently came from the New York City Department of Health as Deputy Commissioner and founding director of the Center for Health Equity there. And so we actually used a model that spoke about how do we normalize conversations around race, power, privilege. So that's all the kind of the training components, creating safe spaces, or I don't know if safe is always the right word, but spaces in which we can have conversations, and they're more common, they're normalized. Another piece of it was how do we organize people across an institution so that you identify champions, you identify ways to create buy-in for many folks across an institution to help develop what these plans and equity action plans will become, so they become embedded within the policies and practices of the institution and also offer sustainability. And then the third part was how do we operationalize? What are those tools that are going to need to be either developed or created so that teams and staff were able to kind of challenge the decisions that they made, whether it was around communications or policy or how you collect data or how you engage with community. So you can't just have the training, because you can also cause damage for the person and trauma as well if the system and the institution doesn't support this new knowledge and understanding of how the world works. Right. So there are folks, and there are now growing organizations that are out there to help support institutions doing this work of transformation from the inside. I'm a believer that you cannot do health equity on the outside if you as an institution have not focused on the inside of what you need to do to evolve it. So we are at the conclusion of our program. I want to thank the panelists. You were amazing. You know, I always, be always transparent. You know, it's so critical to talk about these inequities at the root causes. And sometimes I'm always concerned, am I going to be in an environment where folks are really going to talk about the issues and dig deep? And you all did, and all did beautifully. So I just want to, can you all give them a round of applause for their voice and their advocacy, really, and commitment to this work in many different ways. And also thank you to Jennifer Myers and the Jennifer Bush-Lawson Foundation and Duke and DC for being present here, and for everyone who showed up this morning, for all the students. Y'all, I'm here. Yes. This is exactly how, this starts. We need, I'm a believer. Clearly, I'm at the AMA, which is an advocacy, in a sense, organization and association. But I'm a true believer in using our voice as clinicians and health professionals beyond just within the clinical walls, but also outside of that. So congratulations for you all being here as well. And I'm sure you have access to me if you have any further questions, and want to engage with the AMA, we'd love to have you as well. Okay, so that is it for this morning. Anything else that you want to say? Okay, thank you for coming.